Good evening to all. I welcome you all to this edition of Chennai Pancreas Club meeting. It has been more than 2 years since we all met for this kind of meeting after this COVID. I think this is the first meeting we are coming back after about 2.5 years. It's nice to come back again. It's a very small group. We have a very informal discussion about some interesting cases in pancreas, and we try to learn from this. So to start with, I think we'll start off. We'll have 3 cases for today as of now. I think we'll start off with Dr. Saravanan, who will surgical gastroenterologist at Apollo Proton, who will present his first case, please.
Good evening, everyone. In today's Pancreas Club, I think neuroendocrine was the topic for discussion. This is something slightly atypical. I thought I should bring about this. We had this patient who had both a pancreatic lesion and a lung lesion. Whenever you have dual lesions and you're suspecting a malignancy, we always think, is this metastatic disease that we are dealing with? Or is it by any chance a synchronous primary or a multicentric disease? Is it a different pathology? In which case, is the second pathology a benign tumor or a second primary tumor? Is it a syndromic disease? And finally, from the treatment implication, does it warrant surgery? Do we do it as a staged procedure? Do we do it together? Do we offer chemotherapy and then reassess? So these are the thoughts which come to my mind. So this was a 51-year-old gentleman who was detected to have a pancreatic head lesion and a lesion in the left lung lower lobe, both of which were detected incidentally in August 2019. He underwent a lung biopsy. All this was elsewhere. This lung biopsy, they said query sarcoma. They were not sure. The tissue yield was not very good. So probably a pancreatic primary, or is it a metastasis to the pancreas, or pancreas is something else. With this, he came to us. We suggested him to get a US assessment of the pancreatic lesion and biopsy to see what could come out of it. He, in the meanwhile, went to Tata, Mumbai, very disheartened, came back, long waiting. By this time, the pancreatic lesion progressed a little more. There was suspicion of vascular involvement. So this was the 2 lesions on the PET scan, one in the left lobe, lower lung, and one in the pancreatic head. So the right panel is showing the pancreatic lesion. I'll just go axially down one step by step. So it was a predominantly exophytic kind of a lesion, well encapsulated, heterogeneous enhancement. Center was a little hypointense. So we sent it to Dr. Perama, who did the US for us, and it was again a mass with a loss of fat plane with a short segment of SMV. The biopsy came as a poorly differentiated malignancy, and it was deemed to be not an epithelial neoplasm. So what we knew is that this is not adenocarcinoma, definitely malignancy. Between the two, the pancreas has probably progressed. So whether it has come from lung and going to pancreas, or pancreas to lung, not adenocarcinoma, very good performance status, oligometastatic disease. We had a discussion. We thought we'll offer him surgery. Since pancreas was the one which was progressing, we thought that needs to be addressed first and lung later. He underwent a Whipple's resection. The vessels were free. He underwent without any need for any additional procedure. He had grade 1 pancreatic fistula, discharged after 10 days, needed readmission briefly for a pigtail for a bile leak, bilioma. After that, he went fine. As we can see in this gross specimen, we can see at the outset when we were doing the Whipple, we also had a doubt, is it a peripancreatic lymph node which has which is a metastasis. So we thought we can see if we can enucleate it, but it started bleeding. It was looking intrapancreatic. Just wanted to highlight that this blue arrow is all the pancreatic tissue which we can see, and this is the tumor. So it was well within. I don't think we could have enucleated this lesion. The histopathology was a high-grade neuroendocrine carcinoma, and lymph nodes were negative. The adjacent lymph nodes were negative. Our pathologist raised a possibility of this being a intrapancreatic lymph node or or a lymph node which has been completely replaced by tumor, because there were a few lymphoid aggregates within the tumor that was there, and the IHC was positive for synaptophysin. He was reassessed at 6 weeks. The lung lesion was still static, no disease elsewhere. He underwent a resection of that with the uniportal VATS. This also came as a large cell neuroendocrine carcinoma. The pathologist felt that this is the primary and the pancreas is secondary, based on the fact that the pancreatic lesion was well encapsulated with some lymphoid material within, and there were some IHC features which were probably supportive of a lung primary. So identical histomorphology, a very high Ki67. He was on chemotherapy. He received 4 cycles of carboplatin paclitaxel. Then he had a re-imaging, and what we find is that now he has developed a lesion in the adrenal on the right side, 2 centimeter, non-FDG avid. Initially we thought it was actually reported as an adrenal adenoma, but when we reviewed the earlier imaging, it was not there. So it was difficult to explain why an adrenal adenoma should come up suddenly. So the imaging favored a metastasis, or is it something else, pheochromocytoma? At the primary site, at both the lung as well as the pancreatic bed, nothing else was seen. We ruled out pheochromocytoma. Whatever the biochemical workup was needed, that was done. Again, his performance status was fine. This adrenal lesion was isolated. Should we offer RT? Are we doing an overreach by surgery versus surgery? All that was discussed. Finally, we opted for surgery. He underwent a right adrenalectomy. This was, and it was consistent with, again, large cell neuroendocrine carcinoma. So he had to be offered something else. First line chemotherapy obviously did not work. That's why he's developing meds at different places. He received chemo with immunotherapy this time. He was asymptomatic. However, the scan still shows something new. Now it showed a right psoas deposit. It showed a brain lesion. And beyond this, we didn't have much to offer. He continued to take alternative forms of medicine, did quite well initially for some time, but eventually he passed away. So this is the timeline. He came to us with the diagnosis in August 2019. They had the resections in October and December for the pancreas and the lung. Then the adrenal lesion came in April, had the adrenalectomy sometime in June. Then in Feb he had the psoas and the brain lesion, and he succumbed in November 21. So about 2 years and a little over 2 years. So briefly, can there be metastasis to pancreas? What is the mechanism of such a deposit? And what do we know about a lung primary with abdominal or a pancreatic metastasis? These are the 3 questions which I will try to address. So pancreatic metastases are uncommon, yes, but they are known.
And before we'll take opinions.
Anything you would have done different at every step. I want to know what was the PET scan done preoperatively? Was it a DOTA PET or an FDG PET?
It was a FDG PET. At the initial preoperative, this thing was not in favor of neuroendocrine. Only after the surgery we found out that it's neuroendocrine.
You did a FDG PET suspecting neuroendocrine tumor?
No. It was an unknown malignancy. We knew it was not adenocarcinoma. It was non-epithelial malignancy. That's all we knew.
What are the findings on FDG PET? Was it metabolically active?
It was FDG avid.
That itself probably says that it is a very aggressive neuroendocrine tumor. Because we know that neuroendocrine tumors are very heterogeneous type of tumors. On the one hand, you have a very indolent tumors, and on the other hand, you have a very aggressive tumor. And aggressive tumors are FDG positive. So right from the beginning, there is an indication that this patient is
Bad
not going
disease.
to do good. That's what I feel. But what I would have done is the US guided biopsy. What was the biopsy report?
So that was showing poorly differentiated malignancy, not
Which obviously means that they would have gone for immunohistochemistry markers.
yeah, that also was not very conclusive. They said it's not epithelial neoplasm. That much only they were able to answer.
How could say that? How could
They could not say it is.
No, how could they say that it is not epithelial without doing markers?
With the markers, they could make
Because
out.
when you have a poorly differentiated malignancy, the situation cries for a IHC markers because it could be a lymphoma, it could be anything.
So based on that, they said it's not an epithelial neoplasm, something else, but not exactly they were able to pinpoint at that point.
Now, what was the IHC markers you have done?
I don't have the panel right now.
Because if you have information at that point, probably you could have even done a K67 and whether instead of surgery, whether you would have gone for something like a.
No, that is if we knew it was neuroendocrine at that point. At that point, we didn't have.
No, Saravanan, without markers, how you can rule out neuroendocrine tumor?
No,
That's my point. Of course, now it is retrospectively we can all discuss, but
The idea of the discussion is that now, but what is that we learn from what has happened? Because when you have a pancreatic lesion and a lung lesion, and the pancreatic lesion seems to be aggressive, and then he's going for a very aggressive surgery to start with, and you have,
I think valid point is the IHC. So as for the discussion that we started, whether it's a lung primary and a secondary pancreas, if it turned out to be other way, like it was a lung primary and secondary pancreas, doing Whipple's probably was an overkill. So I think IHC was mandatory. If required, we could have gone in again with an EUS and repeated the sample. I think that should have been the probably one thought process, especially when it showed poorly differentiated neoplasm. So we did have, as Sir said, lymphoma, small cell carcinoma. We know small cell carcinomas of the lung are prone for intraabdominal, especially adrenal. So that occurred later in the timeline, unfortunately, but if it had occurred earlier, I think that would have been the.
How many would have thought about a pancreatic secondary? 99% of the people would have thought only it's a pancreatic primary with going to the lung.
But the location of the secondary was not, it's not a subpleural location, it was a centrally located, more mass forming, without adjoining lymph node. Very unlikely that.
We could have given, we can give ourselves a chance because we know what it is now.
Yes, no, agree.
Otherwise, would you have thought of a primary as lung and secondary pancreas?
No, it is possible, sir. I'm not saying you have to.
I'm not talking about possible.
I mean, Hari, just can I interrupt? No, where US was done where? Yeah. No, Prima, I just want to. I mean, as Hari says, it is a retrospective thought process, but we can talk whatever we want. But the morphology looks like a well circumscribed, well delineated. You understand, no? It looks like something different. Of course, we have all the data now. We can talk whatever we want. Maybe that could throw some different thought process, because any meds.
I have the IHC report. I'll just show you this.
Okay, what about chromogranin A, or what about Dotanex scan? I mean, did they go through your mind since?
We did
No,
the.
when you have a suspicion, when you are going for a Whipple's procedure, I mean, when you have, okay, that's ultimate.
If you see a resectable tumor, even if it is net, won't you wait
After
for
the
it or
Whipple's
go
only,
for
we
resection?
knew that it was neuroendocrine.
Invariably go for surgery.
Before
no?
the Whipple, we didn't know, because even the imaging wise.
Oh, Saravanan, it was a FDG PET proper triphasic CT, no? FDG is the proper triphasic CT. It was not hypervascular.
It was not hypervascular.
Okay.
And the display ala.
My question is that, would somebody have not gone for a Whipple? If you have question.
The thing is, whatever may be the imaging it was not hypervascular. All the more that you will have to think whether it could be a pancreatic ductal adenocarcinoma. Because FDG avid lesions, metabolic lesions in pancreas and lung. So it could be anything. and it was not a classical of neuroendocrine tumor on imaging contrast enhancement. So, and they got a tissue diagnosis. They got a tissue diagnosis which was poorly differentiated malignancy, which means you have to do IHC markers, because if it comes as lymphoma, you can just give chemotherapy.
Yeah, I have
So
the IHC.
in the presence of
I have the IHC. I'll just show that to you.
obviously, I would have not done a Whipple's in the presence of a lung lesion.
So this is the IHC.
Yeah, that's what I'm.
Can I come to the
IHC? This retrospect can be anything, but.
No, this is the IHC at the US. So the US IHC was negative for CK7, CK20, CEA, CK19, which is predominantly all the adenocarcinoma, those kind of markers. And neuronal markers, they did synaptophysin, chromogranin, they were also negative. So we were not any wiser, and I don't know, lymphoma they have not looked at, probably because the morphology didn't suggest.
The issue is when we have a lesion in the pancreatic head, the poorly differentiated, feature, and there's a lung lesion. Well, I'll think a lot of times before I go in, because it's a very aggressive surgery you're going to undertake, and if you undertake a surgery, that should be a curative surgery. And then I'll not, pancreatic malignancy with a lung lesion, I will not think of Whipple's plus a pulmonary resection, because that would be too far-fetched.
Because we thought that we knew for sure this much from the pathologist that this is not adenocarcinoma. If it was a pancreatic adenocarcinoma with a lung met, it was too much to offer. So this is some other non-adenocarcinoma malignancy. Lung also was biopsy, that came as sarcoma.
Again,
actually,
it's
to
a
be
very
frank,
highly sort of malignant sort of a lesion in the.
This for the, actually, I offered the patient that let's biopsy the lung again, but by this time the patient had lost it. He said, enough, I have had this. How many times do you want to prick me? So it was. I actually told him we collect because the lung was not done with us.
Hari, just speak into the mic.
No, my question is that how many of these surgeons, you have done a Whipple. Their situation, they are also not aware. But would they have gone for a Whipple? Radha doesn't want to go for a Whipple. Shankar doesn't want to go for a Whipple. I don't know. What's the reason?
No, because I don't know the nature and it seems so aggressive. I want to know what the lung lesion is. If lung lesion turns out to be something inconsequential,
It came out of sarcoma,
then I will not. Because, yeah, I mean, if it came out in net, it's a different issue. But then if the nets, if the patients live longer and we have appropriate medical management, because if sarcoma doesn't have any proper follow-up management, poorly differentiated malignancy, not, I don't know, he always disagrees with me. I don't know whether I disagree with this.
No, sir. If it had come out as neuroendocrine tumor even at one place, then obviously we would have gone for a Dotonac to prove, and FDG is already away. Now we know it's an aggressive tumor. Probably I would look for non-operative management like a PRRT, rather than going for an aggressive surgery both ways, both in the lung. I don't know which will be the primary. Pancreas can be the primary with the liver, lung mets, or a lung with the primary, but we could have gone for a PRRT.
I'm trying to find fault that they have gone for an aggressive surgery.
No, I'm just saying.
At the end of the day, surgery is the one that's going to cure anybody. So, but the level of aggressiveness is what we are trying to find out. If Shankar doesn't want to go, Radha doesn't want to do, and the thing is that I'm asking justification for Whipple. Probably because of Whipple, he survived a little longer. I don't know.
The same Whipple could have killed him also, in which case we would have regretted the decision. But yeah, it's a calculated risk.
My question was that the level of aggressiveness, that's what I'm talking about.
Even if it is neuroendocrine, suppose we had found it as neuroendocrine tumor and he had a lung mets, is there a role for debulking in such patients, or you just offer only what he said, radionuclear therapy?
Sir, actually, the biopsy showed neuroendocrine carcinoma, not tumor, right?
It's a carcinoma, fine.
So no, NEC is the 4th stage. So WHO classification padi, you have NET grade 1, grade 2, grade 3, and NEC is the most aggressive.
Right.
So once you already knew that this is a neuroendocrine carcinoma, was there any use of going ahead and thinking this is a pheo or that adenoma? I mean, he didn't have symptoms of a pheochromocytoma. And you know neuroendocrine carcinoma has a median survival of 6 to 12 months. He survived 2 years, I think that's fantastic, sir. But I think paclitaxel, etoposide and cisplatin would have done the job. Why should we go for a third surgery? Already you did it 2 times. Why the third surgery? Even PRRT may be an advanced treatment, may be expensive, but why the third?
I think what he says is absolutely, I mean retrospectively, but once it's a neuroendocrine carcinoma, I think nothing much can be done. Only medical therapy, maybe chemo. These are the cases of NET with chemo. No. Whatever we do, the survival is less than 1 year.
If no, you won't. Funny, you won't offer the patient surgery, yeah?
No, neuroendocrine carcinoma, if it comes, I think we have to.
See,
Mostly.
the bottom line is patient survived 2.5 years.
No, but even then, 2 years is not a long.
Because of surgery.
It's because surgery.
Yeah. Yeah.
Although it can't be scientifically validated, but you know, I mean, that's what
I don't know,
Pyramid. If you have not done anything, I don't know how to survive.
Pyramid or Ubal, I don't know whom either of you should have done. The patient came later to us. You had done a biopsy for a small vocal nodule, just very small vocal nodule. Tiny, 2 millimeter, 3 millimeter something. It came as neuroendocrine carcinoma. He's a medical person, ENT surgeon. I don't know whether you remember him. He survived for less than 1.5 years. He was a very young chap, extensive metastasis. So then at that time only we understood that if a word neuroendocrine carcinoma, it's a verdict.
Yeah, I mean, if you know it is neuroendocrine
It's all
carcinoma,
retrospective.
then usually, in fact, if suppose many people would not even proceed, if suppose isolated pancreatic neuroendocrine carcinoma, no metastasis, many people would not offer a Whipple because anyway they will have systemic disease very soon. In this patient, I agree that the first 2 things were okay. Adrenal, yes, at this point, maybe we should have called it a day and not
It's all
offered him
lessons
anything.
only. It's all lessons what we learn.
Though the only thing we got a little carried away or we were too positive was actually this lesion was not FDG EVIT, the adrenal lesion, number 1. Number 2, it was not enhancing. So we just thought, could it be something else, you know? And since this patient was well, that's why this thought process of pheo. Otherwise, if you look at it straight, yes, once neuroendocrine, it should be again the same thing.
And probably we could have followed up with a DOTA rather than a FDG PET because we
did
knew
that.
it's already an NET
So
case.
we did that, it was DOTA negative. So that's why all the further imagings were all FDG PET. And I don't know why this was not FDG EVIT.
If you sit on the table, sit face to face with the patient and the patient wants surgery, I don't think the surgeon has got a choice except to operate. But
We did think of something less aggressive, radiotherapy. You are not treating anything, you're treating it something and waiting. But the disadvantage to that was twofold. One, we would still not know the tissue diagnosis of this adrenal because we were not sure what it is. And
Saravanan, did you subject this patient to the multidisciplinary tumor board, and what were the options? I'm sure there are many options in this.
Yes, the radiation oncologist came with RT. The radiation oncologist came with, if you're not operating, we'll give radiation.
That is an option.
The thing is that if you're not operating, no. But
What is the...
It should be the tumor board has to come with some conclusion as to what would be the best option.
So we thought that radiation will not give us the tissue diagnosis, number 1. The other thing is then we have to just put in a needle, take a biopsy, and then based on that take a call. But again, I don't know, we got carried away with this performance status and everything. So pancreatic metastasis is uncommon, known more so in settings of RCC, in which case metastatectomies are known to be useful. And if you look at the mechanism, and when we looked at the mechanism of such a pancreatic metastasis happening, it's probably likely a nodal spread which has then subsequently gone on into the parenchyma. This is what people have looked at. And there are series of lung primary where they have had incidence of pancreatic nodal metastasis, and the results have been dismal. Most of them have succumbed within less than a period of a year. And abdominal sites of metastasis from a lung primary are also known. If they are in a non-metastatic setting, the 5-year survival has been somewhere in the range of 30%. Once it is metastatic, and most commonly we are worried about brain mets in such patients, and they have survived for less than a year. Probably one of the longest survivors in such a situation has been a case of lung with a liver lesion who has survived for about 4 years till the last follow-up. So coming to the role of a metastatectomy in a pancreatic situation, an individualized decision has to be made. The pathophysiology, as we said, could be because of a nodal encroaching onto the parenchyma. Adjuvant chemotherapy usually in such situations is cisplatin etoposide. And surveillance has to be brain directed because that is where it is the most common site for disease. Not all neuroendocrine are gastrointestinal. Oligometastatic disease, we have to discuss the advantage of surgery vis-a-vis test of time with chemotherapy, and if they still continue to do well, then only offer surgery. In this case, the diagnostic, there was a diagnostic question mark initially with the biopsy not able to give us a clear clue. The quality of life was reasonable with these surgeries. However, we wonder how worthwhile this was because the cost incurred in this survival process, I think this patient would have spent nearly about 15 lakhs or so for this survival of 2 years, and the disease-free interval was very small. But yes, it was heartening to some extent. This is the WhatsApp message which I got from the patient on the Diwali, and then his daughter had messaged me and said thanks for everything. Thank you.